You just got your blood work back. Your doctor glanced at the results, looked up at you, and said the three words everyone in that waiting room hopes to hear. Everything looks normal. And you nodded. Maybe you even felt relieved for a moment. But here's what I need to tell you right now. That panel almost certainly does not include the 5 blood tests that matter most for someone your age. Not because your doctor is wrong, but because the standard panel used at most routine physicals in America was designed decades ago, and it was never updated to address the specific biology of aging. I want to speak to you directly today. If you are in your 60s or 70s, you have probably spent years being told that what you feel is simply part of getting older. The fatigue, the mental fog, the occasional irregular heartbeat that comes and goes, the muscle weakness that never quite has an explanation. What most people sitting in that exam room never find out is that each of those symptoms can be traced to a specific biological system, and that system can be measured. You simply have to know which tests to ask for. Today I am walking you through 5 blood tests, ranked in the order I believe you need them most. There is a reason your doctor has never brought these up, and I will explain exactly what that reason is at the halfway point of this video, because understanding it will change how you walk into your next appointment. One of these tests involves a finding from a study of more than 500,000 people that I believe will genuinely stop you cold when you hear the number. By the end of this video, I will also tell you about a patient whose health turned around completely once we found what was hiding in his blood. And I will give you the exact words to use with your doctor to make sure you leave your next visit with every one of these tests on your order sheet. I personally read every comment you leave below. This video runs about 25 minutes, and the most important information comes in the second half. You had breakfast this morning, probably a reasonable one. Toast, some fruit, whatever you usually reach for. You do not know this, but somewhere in the 2 hours after that meal, your body was either handling it with quiet precision, or it was struggling in a way that no standard blood test you have ever received would reveal. The test that tells you which is true is called a fasting insulin, and it is one of the most consistently overlooked pieces of metabolic information in senior care. When your doctor orders a blood sugar test, they are measuring how much glucose is floating in your bloodstream at a single moment in time. It is a snapshot. Fasting insulin works entirely differently. It measures how hard your pancreas has to work to keep that blood sugar in check. And that difference matters enormously, because insulin resistance, the condition where your cells have stopped responding efficiently to insulin, can be silently damaging your heart, your brain, and your blood vessels for a decade or longer before a single standard blood test shows anything abnormal at all. A prospective cohort study published in PLOS Medicine followed 3,246 women between the ages of 60 and 79, all of them free of diabetes and cardiovascular disease at the start. Researchers measured fasting insulin, fasting glucose, and glycated hemoglobin, then tracked these women over time for heart attacks and strokes. The finding was direct and striking. Fasting insulin was an independent predictor of coronary heart disease and stroke in these older women, while neither fasting glucose nor hemoglobin A1C showed any meaningful association with those outcomes. In women aged 60 to 79, insulin resistance, not blood sugar, not the test most doctors rely on, was the more important cardiovascular risk factor. Think about that the next time someone hands you a result and says your glucose is fine. The biology is straightforward once you see it. When your cells stop listening to insulin, your pancreas produces more of it to compensate. That prolonged elevation damages the lining of your blood vessels, the way a slow, sustained pressure eventually cracks a wall. You would not know from the outside until something gave way. The most common mistake I see is people assuming that because their A1C is normal, insulin is not an issue. Those are two entirely different biological signals, and only one of them catches the problem at its earliest stage. You want your fasting insulin below 10 micro-international units per milliliter. Optimal is below 5. If yours is above 15, that warrants a direct conversation with your physician about insulin resistance, even if every other metabolic test comes back clean. This is a simple fasting blood draw, ordered the same morning as everything else. Within 3 to 6 months of dietary adjustments guided by this result, many people describe sleeping more deeply and waking with an energy they had almost forgotten was possible. The next test most people have never heard of is responsible for one of the most preventable cardiovascular disasters in adults over 60, and its mechanism of harm is completely invisible to a standard cholesterol panel. If you found this video through a search, you may not know this resource exists. I release a new video every single week with health information made specifically for people in their 60s, 70s, and 80s. Press the subscribe button just below this video. It is the one step that makes sure this information keeps reaching you. Not subscribing means the next video, which may contain something even more relevant to your specific situation, will simply never find you. Here is something your cholesterol report has never told you. Inside the same family of lipid particles your doctor measures every year, there is one specific particle that is genetically determined, does not respond to statins or dietary changes, and dramatically raises the risk of heart attack and stroke in roughly 1 in 5 people. It is called lipoprotein a, written Lp(a), and the number of seniors walking around with a dangerously elevated level who have no idea is astonishing. A landmark prospective study published in the New England Journal of Medicine followed 5,888 community-dwelling adults aged 65 and older for a median of 7.5 years. Researchers from the Cardiovascular Health Study found that elevated Lp(a) was an independent predictor of stroke, death from vascular disease, and death from all causes after full adjustment for traditional cardiovascular risk factors, including LDL cholesterol, blood pressure, smoking, and diabetes. That means Lp(a) was raising risk on its own, not riding the coattails of other known problems. Think about that the next time someone tells you your cholesterol panel looks fine. What makes this test so urgent is the specific way Lp(a) causes damage. Unlike ordinary LDL cholesterol, Lp(a) has a unique protein attached to it that interferes with your body's ability to dissolve blood clots naturally. It is simultaneously atherogenic, meaning it builds up inside artery walls, and thrombotic, meaning it prevents your body from clearing the resulting blockages. Your arteries absorb it, the standard lipid report never sees it, and most physicians never order the test that would find it. Here is a number that should make this concrete. According to utilization research, fewer than 2% of patients who receive a standard lipid panel are ever tested for Lp(a). That is not a typo. 1 in 50. If your Lp(a) is above 50 milligrams per deciliter, that information is immediately actionable. It changes how aggressively your physician should address every other cardiovascular risk factor in your overall picture. Ask your doctor to add Lp(a) to your next lipid panel by name. It requires no additional needle stick, only a single added line on the lab order. One test, one conversation, results usually back within days. And unlike the next item we are about to cover, which requires a slightly different specimen collection, Lp(a) is completely straightforward to order at any major laboratory. What comes next surprised even me the first time I read the research, because it involves a biological system that most seniors have never once connected to the symptoms they feel in the middle of the night. You have now heard about 2 blood tests, almost certainly absent from your current medical record. 2 different biological pathways, 2 completely different kinds of silent risk. Before we move forward, I want to give you something that genuinely surprised me when I first read the literature. A standard serum magnesium test, which many of you may have had done as part of a routine panel, can appear completely normal, even when true cellular magnesium deficiency is present, because your body pulls magnesium out of cells to protect blood levels. The test that actually reveals what your heart muscle has to work with is a completely different test. And coming up next, there is one finding still ahead in this video, connecting a familiar liver number to cardiac death in over 527,000 people that you have most likely never been told about. You have stayed with me through 2 important findings, and that matters. If this video is giving you something useful, press the like button below. It makes this easy to find again when you want to share it. We have covered fasting insulin, which exposes silent cellular resistance that standard blood sugar tests miss entirely, and Lp(a), the inherited cardiovascular particle that no standard cholesterol panel ever measures. And here is the answer to the question I planted at the beginning. Your doctor does not order these tests because standard blood panels were designed decades ago for a broad adult population and were never meaningfully updated to reflect what 40 years of geriatric research now tells us about the specific vulnerabilities of aging biology. That is the reason, not neglect. But knowing it changes how you walk into your next appointment. One test still ahead involves a study of more than 500,000 people, and the finding that comes with it will genuinely stop you. The most important information is still coming. I do not want you to miss what is ahead in the second half of this video, but I also do not want you to miss what comes in the weeks following. Next week, I am releasing a video on the 5 warning signs of early kidney decline in seniors that most physicians do not screen for at routine visits. Warning signs that show up in your blood years before any symptoms appear. Press subscribe right now. It is free, and that video will come directly to you so you do not have to find it by chance. You wake up at 2 in the morning and your heart is doing something strange. Not painful, just different. A flutter, an extra beat, a brief sensation that your chest is slightly out of rhythm. You lie still and it passes. You mention it at your next appointment, and your doctor says the EKG looks fine. What almost no one tells you is that a normal EKG cannot reveal whether your heart cells have the mineral they need to maintain proper electrical timing. That mineral is magnesium, and the blood test your doctor routinely orders for it misses true deficiency the majority of the time. Here is why this happens. When your body's magnesium drops, your blood is not the first place it shows. Your body is designed to preserve blood levels at the expense of your cells. It pulls magnesium out of muscle tissue, out of heart cells, out of your neurons, to keep the number in the blood looking acceptable. The serum magnesium test, the one your doctor orders, measures what is floating in your bloodstream. What you actually need is the RBC magnesium, which measures magnesium inside your red blood cells and gives a far more accurate picture of what your heart and muscles have available to work with. A study published in the journal Circulation, using data from the Framingham Offspring Study, following 3,530 adults over up to 20 years, found that those in the lowest quartile of magnesium had an atrial fibrillation incidence rate nearly 50% higher than those in the highest quartile. 9.5 cases per 1,000 person years, compared to 6 per 1,000 in the most protected group. Atrial fibrillation at your age is not an inconvenience. It is one of the leading causes of stroke, heart failure, and emergency hospitalization in adults over 65. If you have ever felt an irregular rhythm in your chest at rest, that finding deserves your attention. Magnesium governs more than 300 enzymatic reactions in your body, including every step of energy production inside your heart muscle. Think of it as the electrical insulation on a wire. When it thins, the signals begin to misfire. The most common reason seniors are low, despite eating reasonably, is that several widely prescribed medications actively deplete cellular magnesium over time. Proton pump inhibitors for acid reflux, loop diuretics like furosemide, metformin. If you are on any of these, this test is not optional. Ask your doctor for the RBC magnesium test specifically, not the standard serum magnesium. These are 2 different tests, and only one of them tells the full story. A result below 5.5 milligrams per deciliter warrants serious attention. Most people who correct a true deficiency describe better sleep, fewer nighttime cramps, and a noticeably calmer heartbeat within 6 to 8 weeks. The next test measures something your doctor learned about in medical school, but almost certainly has never ordered for you. It is a measure of biological aging at the hormonal level, and it has been quietly declining in your body for decades. I want to pause here and ask you something directly. Have you ever woken up in the night with an irregular heartbeat or a racing pulse that just passed on its own? Leave your experience in the comments below. I personally read every single one, and your answer helps everyone watching know they are not alone. You have now covered 3 tests representing 3 completely different biological systems: insulin signaling, cardiovascular genetics, and cellular mineral metabolism. Before we move to the final 2, here is something most physicians do not realize. The adrenal hormone in the next test declines at roughly 2% per year beginning in your 30s, meaning that by age 70, most people are operating at less than a quarter of their lifetime peak level. And the very last test on this list is hiding inside the same routine lab report many of you may have already received, but the number inside it has never been explained to you the way I am about to. If you have stayed with this video this far, you already know something about yourself. You take your health seriously, and you are willing to act on what you learn. I want to ask you personally, press subscribe below if you have not already. This information is built for you, every single week. It takes 5 seconds. It is free. Picture your body as a country with a reserve supply, a stockpile of biological resources it draws on to handle stress, illness, physical exertion, and the ordinary demands of each day. In your 20s and 30s, that reserve is near its peak. By your 60s and 70s, it has been drawing down for decades. Most doctors have never once measured how much reserve you actually have left. The test that reveals it is called DHEAS, and it is one of the most consistently overlooked markers in senior medicine. Dehydroepiandrosterone sulfate, which we abbreviate as DHEAS, is the most abundant steroid hormone in the human body. Your adrenal glands produce it. Your body converts it as needed into estrogen, testosterone, and other hormones that regulate immune surveillance, cardiovascular function, energy metabolism, and the preservation of lean muscle mass. After the age of 30, DHEAS declines steadily at roughly 2% per year. By the time most people reach 70, their levels are 70 to 80% lower than their lifetime peak. What that means clinically was captured in a meta-analysis published in the journal Annals of Palliative Medicine that pooled data from 6 prospective studies totaling 6,744 elderly individuals. Adults with the lowest circulating DHEAS levels had a 46% higher risk of death from all causes and a 49% higher risk of death from cardiovascular disease compared to those with higher levels. A 46% increase in all-cause mortality from a hormone your doctor has most likely never once measured or discussed with you. That is what 6 studies and nearly 7,000 elderly individuals showed. The biological pathway is distinct from everything we have already covered. DHEAS does not directly lower blood pressure or clear arterial inflammation on its own. It appears to function as a broad biological buffer, maintaining the integrity of the endothelial cells that line your arteries, supporting immune function, and helping preserve the muscle reserve that protects against the physical frailty that leads to falls, hospitalizations, and the loss of independence. When it drops below what is expected for your age, your body loses a layer of adaptability it has relied on for your entire life. You want your DHEAS measured against age-appropriate reference values, not simply compared to a general adult range. A healthy 40-year-old has very different expected levels than a healthy 72-year-old. The relevant question is whether your level is appropriate for someone your age, who is aging at a healthy biological rate. If it is significantly below age-expected norms, that deserves a direct conversation with your physician. This is not a supplement I recommend casually. DHEA involves hormonal pathways that interact with prostate health in men and certain hormone-sensitive conditions in women, and any intervention should be medically supervised. What most people notice first, when their level is appropriately addressed, is the return of something they stopped naming a long time ago: energy with purpose, the feeling of reserve. The last test on this list has been hiding in plain sight in a lab report you may already have in a drawer somewhere. But no one ever told you what the number inside it means for your survival. There is a number sitting inside a routine liver panel that your doctor almost certainly ordered at your last physical. You have seen it before, buried in the middle of a page of results, listed as a small abbreviation next to a range you never paid attention to. That number is your GGT, gamma-glutamyl transferase, and it has been universally misunderstood as a liver enzyme. What it actually represents, and what decades of research across hundreds of thousands of people has confirmed, is something far more significant. GGT is an enzyme produced primarily by the liver, but it operates throughout your entire body as part of the system your cells use to manage oxidative stress. When your tissues are under chronic inflammatory load, when cellular damage is building at a rate your antioxidant systems cannot contain, GGT rises. It is, in the most practical sense, a signal flare from inside your biology, indicating that something has been burning quietly for a long time, silently preparing the conditions for a cardiac event. A meta-analysis published in PLOS One examined 9 prospective cohort studies, totaling over 527,000 participants, and found a clear, measurable dose-response relationship between rising GGT levels and death from cardiovascular disease. Adults with the highest GGT levels had a 59% higher risk of dying from cardiovascular causes compared to those with the lowest levels. Every 10-unit increase in GGT was independently associated with a 10% increase in cardiovascular mortality risk. This held true across men and women, independent of every other known risk factor. More than 500,000 people. a clear dose-response curve, a number already in your chart that no one has explained to you. The mechanism is one your standard lipid panel cannot capture. GGT accumulates inside atherosclerotic plaques and coronary arteries, not as a passive bystander, but as an active accelerant, catalyzing the oxidation of LDL cholesterol inside those plaques and making them more unstable and more prone to rupture. It is the difference between a fire that smolders and one that suddenly breaks through a wall. Most laboratories report a normal GGT as anything below 50 to 65 units per liter. But research consistently shows that cardiovascular risk begins rising well below that threshold, in what labs quietly label as the upper portion of normal. You want your GGT below 25 units per liter for meaningful cardiovascular protection. If yours is above 40, that number warrants a direct and specific conversation with your physician, regardless of what the rest of your liver panel shows. You have most likely looked at this number before and never once been told what it means for your heart. Now you know. Before your next appointment, write down 5 names: fasting insulin, LPAA, RBC magnesium, DHEAS, and GGT. Bring that list to your doctor and ask for all 5 to be added to your next blood draw. If insurance coverage comes up, many of these are available through Quest Diagnostics or LabCorp for between $20 and $50 out of pocket per test. GGT is frequently included in a comprehensive metabolic panel your doctor may already be ordering. Fasting insulin and RBC magnesium are the 2 most commonly absent because they require the physician to add them by specific name. RBC magnesium also uses a different collection tube, so let the laboratory staff know in advance so they are prepared. On the morning of your draw, fast for at least 10 hours beforehand. This matters most for fasting insulin. Even a light meal can shift the reading enough to obscure early resistance. Drink water. Take your usual medications unless your physician advises otherwise. Here is what to realistically expect over the first 2 months. In weeks 1 and 2, you are gathering information. No intervention yet. You are building a complete and honest picture of where your biology stands right now. In month 1, after you review results with your physician, you may begin addressing specific findings. If fasting insulin is elevated, reducing refined carbohydrates and added sugars typically produces measurable changes in 4 to 6 weeks. If RBC magnesium is low, magnesium glycinate or magnesium malate are generally well tolerated by older adults. Discuss the specific dose and form with your physician. If DHEAS is significantly below age-expected values, that conversation requires careful individual assessment. Do not supplement DHEA without medical supervision. It can interact with prostate health screenings in men and with hormone-sensitive conditions in women. One specific caution applies to GGT. If yours is elevated and you are currently taking a statin medication, raise that explicitly with your physician. Statin use can occasionally elevate liver enzymes, and a rising GGT in combination with statin therapy warrants closer monitoring over time. A month from now, you will likely know more about your actual biological health status than at any point in your adult life. That knowledge is not a burden. It is agency over your own body, returned to you. I want to tell you about the patient I promised at the beginning of this video. His name was Francis. He was 71 years old. His daughter brought him in because she had noticed a change over the previous year. Slower, quieter at dinner, less himself. His standard labs were entirely unremarkable. Blood sugar fine, cholesterol borderline but not alarming, kidney function normal. On paper, he looked like a man in reasonable health for his age. His DHEAS came back at 19 micrograms per deciliter, profoundly low even for a man his age. His fasting insulin was 22. His GGT was 54. 3 of the 5 tests from today, all abnormal, all completely invisible to the standard panel that had been called normal twice. I want to say something to you directly. You have spent years being told that how you feel is simply what happens after 65, that the fatigue is expected, that the brain fog is just time passing, that the breathlessness going upstairs is normal aging. I am here to tell you that this is not always true. Sometimes what you feel is a signal from a body that is trying to communicate something specific, something that can be found, named, and addressed. Here is the statement I want you to remember from this video, the one thing I would ask you to write down. Your biology is not finished making choices about your future. These tests do not predict your fate. They reveal your options. That distinction matters enormously. And here is what I am asking you to do tonight. Not a supplement, not a lifestyle overhaul. Just this. Write down those 5 test names on a piece of paper. Fasting insulin, Lp(a), RBC magnesium, DHEAS, and GGT, and put it somewhere you will find it before your next appointment. That is where this begins. That is the moment you stop being a passenger in your own health. I want to ask you one question before you go. Of the 5 tests we covered today, fasting insulin, Lp(a), RBC magnesium, DHEAS, and GGT, which one surprised you most? Leave your answer in the comments below. I personally read every one, and your response helps every other person watching feel less alone in this. If this video was useful to you, press subscribe or tap subscribe right below. It is free, and it is the way YouTube sends you the next video, so you do not have to search for it again. Next week I am covering something that will matter to almost everyone in this audience. The connection between commonly prescribed blood pressure medications and accelerated bone density loss in seniors. And there is one class of medication that new research links to a 37% increase in hip fracture risk. You will want to see that one before your next prescription refill. To every person who watched this full video today, please remember that I am a physician, but I am not your physician. Everything shared here is for education. Before requesting any of these tests, making changes to medications, or beginning any supplement, speak directly with your own doctor. Your physician knows your full history and is the right person to guide what the findings mean for you specifically. Take care of yourself. You deserve that.